Avoiding storm damage in the scleroderma hand, contractures, ulcers, and calcinosis. I'd like to first thank Dr. Lee Shapiro for his contributions to today's discussion, as well as his over 15 years of mentoring me with this disease. I'm fortunate to have a close working relationship with him. He's an internationally recognized expert in this field, and he's been a huge supporter of early referral to hand therapy. I would also like to take this opportunity to thank the American Society of Hand Therapists for this wonderful privilege of presenting at the annual meeting. I've been at the Hand Center at Albany Memorial, a division of Trinity Health, for over 25 years, and I have nothing to disclose. This is a great quote when it comes to this illness. 60 years ago, I knew everything. Now I know nothing. Education is a progressive discovery of our own ignorance. This is very true of my understanding of scleroderma. I really feel like I have my index in the ocean as far as information is concerned. It's a very complex disease. I'm constantly learning, and then I'm challenged to assimilate and upgrade my treatment based on what I learn. So it's constant. So what are the takeaway messages from today? A basic understanding of the history and symptoms of systemic sclerosis, a review of the vasculopathy in systemic sclerosis and its role in damage to the upper extremity soft tissue, and a discussion of how we as hand therapists can potentially mitigate the damage to soft tissue in the upper extremity as we advance our expertise with this population. Just by way of information, I'll be using the term systemic sclerosis and scleroderma interchangeably today. Scleroderma, scleros means hard and derma means skin. It's an autoimmune connective tissue disease characterized by excessive collagen deposition in the skin and internal organs with associated vasculopathy and autobody production. When was it first identified? There's records that Hippocrates described it as early as possibly 400 BC, Curzio in 1753, Gintrac in 1847, and then Maurice Raynaud first described Raynaud's phenomenon in 1852 and associated it with scleroderma in 1871. He actually wrote numerous articles on it. And Sir William Osler made the diagnosis of scleroderma at Johns Hopkins in between 1891 and 1897. Epidemiology. The rate of occurrence in the US is estimated at 300 per million. Dr. Shapiro feels that that's a bit low. By comparison, MS is approximately 1,500 per million. Women outnumber men. It's estimated from 4 to 1 to 6 to 1. There's a higher prevalence amongst African Americans. Peak incidence is 45 to 54 for African Americans and 65 to 74 for European Americans. It's rare in childhood. Multi-case occurrence in families is reported. We have actually had a father-daughter and a mother-daughter clients at the Hand Center. But what's definitely present is reports of other autoimmune diseases amongst first-degree relatives, and that's very common among my patients. Environmental triggers, crystalline silica, silica dust, solvents, and vinyl chloride are all amongst the biggest offenders. The diagnosis is made by a rheumatologist. Their blood tests are positive early. There's many different ANA patterns which define subgroups. It's very complex. It's positive in 70 to 90% of individuals. Raynaud's phenomenon occurs with this disease always, and it's considered secondary, not primary. Skin thickening, which is diagnosed by the modified Rodnan score, biopsy, and now there's an emerging shear wave elastography, which is done by ultrasound. Telangiectasias, hypertension, GERD, shortness of breath, and joint pain are all amongst the main symptoms. The modified Rodnan score is administered by a physician, a PA, nurse practitioner. It requires a 2-week certification course. There's 17 different body areas that are assessed. The maximum score is 51. There is some subjectivity in the administering of this disease, which is likely why there's the emerging ultrasound technology that in the future will likely be interfacing with the Rodnan score. But right now, the modified Rodnan score is the gold standard, and it's done on everyone who has been diagnosed with scleroderma. The natural history of the disease of those with limited versus diffuse scleroderma is very different. They differ not just in the extent of skin involvement, but in the rate of progression. Limited form is characterized by skin thickening that's confined to areas distal to the elbows and knees and is generally associated with less severe internal organ involvement. Diffuse form involves skin thickening proximal to the elbows and knees and is associated with more severe internal organ damage. So with limited scleroderma, many of us are familiar with the acronym CREST. It refers to calcinosis. We're going to be talking about that in detail, some detail. Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, which literally means hard fingers, and telangiectasias, those broken blood vessels, often on the face, sometimes across the breastbone. They're common in limited scleroderma. Diffuse systemic sclerosis has a 3 to 5 year period of activity. There are 5 to 10% who may have flares in later years. The disease isn't gone in 5 years. What remains is storm damage. Now you see where I got my title. Pulmonary fibrosis, joint contractures, renal impairment, esophageal weakness, and overlap of myositis is common with diffuse. There's variability in disease aggressiveness, fast lane versus slow lane. This is apparent very quickly after disease onset. Rapid progression of skin thickening means higher risk of internal organ damage. And Dr. Shapiro often says that he wishes he could tell immediately who is going to be a fast lane versus slow lane individual, because obviously the fast lane individual requires very quick clinical intervention. So let's talk about what happens to the blood vessels in systemic sclerosis. The triggers for vascular injury are actually largely unknown, unfortunately. It's thought that ischemia, reperfusion, as well as environmental factors, both chemical and microbial, cause immune activation. This results in endothelial damage and dysfunction in the blood vessel walls, the endothelial lining. The lumina becomes narrow, causing hypoxia and further tissue ischemia. Fibroblasts and myofibroblasts are activated. There's this then resultant platelet activation and thrombosis, and it's a pretty horrible cycle. Simplified, the vascular system becomes damaged and fails to repair itself as you'd see in a normal, healthy individual. To better illustrate what's happening at a capillary level, let's go back to the universal curiosity of shining a flashlight through your hand on a summer night. I'm pretty sure that that was a start of my obsession with observing hands as a little kid, and maybe for many of you as well. It was a pretty fun thing to do. Nail fold capillaroscopy is an in-office procedure that actually has been around since 1925, and it's a very sophisticated version of the flashlight obsession. So in image A, we see well-preserved in early disease, well-preserved capillary architecture and density of dilated giant capillaries. In image B, notice there's frequent giant capillaries and actual hemorrhages, as well as loss of that dense architecture we see in image A. Now in image C, we can really see the damage in late systemic sclerosis. There's an absence of giant capillaries. They're what's called arborized or tortuous capillaries. And there's an actual absence of capillaries known as capillary dropout and architectural disorganization. In image D, we see normal capillaroscopy of a healthy individual. I want you to kind of think on these images as we talk later on about how we'd like to intervene in the hand with this population. So in summary, the endothelial cells lining the blood vessels are the first target of the autoimmune response. I heard one account where they saw the changes in the endothelial lining before the blood tests were actually positive. It occurs early. Apoptosis or cell death in the endothelial lining occurs. So one theory that in response to that, platelets are activated to release serotonin and other profibrotic mediators, which is great and we want to see in healthy individuals. In contrast, this chronic vasculopathy and the persistence of this fibrotic tissue repair is the cyclical link between vascular disease and the fibrosis that we see in scleroderma. Then we have scleroderma overlap syndrome. There's mixed connective tissue disease, myositis, which is huge, and many of my patients have it. Rheumatoid arthritis, Sjogren's is very common companion of this illness. Lupus is an overlap syndrome. Antiphospholipid syndrome, sarcoidosis, and autoimmune liver disease. Those are all potentials. So what are the complications? As if it couldn't get any worse, pulmonary hypertension or interstitial fibrosis, cardiac disease, what's really pericardial disease. I do have one patient who's had to have windows cut in her pericardium twice because of this. Renal disease, renal crisis, esophageal stricture, GI dysmotility and malnutrition because of malabsorption, digital ulcers and autoamputation, which is going to be the focus of future discussion today, painful calcifications at fingertips and elbows with the risk of infection, severe sclerodactyly and foot problems, dental, oral problems, diminished oral opening, eye complications, muscle weakness, myositis, and severe fatigue. So as you can see, these can be very complex individuals to take care of. So some of the pharmaceuticals used in treatment, there's corticosteroids, methotrexate, immunosuppressives. A common one is Celcept or mycophenolic acid. ACE inhibitors, the calcium channel blockers, are used to prevent renal crisis, and actually renal crisis used to be responsible for 40% of deaths in scleroderma, and it's been largely averted by the use of ACE inhibitors, which is wonderful. Vasodilators for Raynaud's, proton pump inhibitors, biologics such as Rituxan, there's a whole emerging field of biologics, and then hydrochloroquine or Plaquenil. Our mission in early disease is to minimize storm damage. That's the theme of today. So let's start to look at what scleroderma looks like. No two people are exactly the same, and that's especially true with scleroderma. There's always a unique presentation. What's our role as a hand therapist? Providing early intervention should be front and center with this disease that manifests itself first in the hands. That's going to require communication with local rheumatologists. Late referrals when collateral damage has become severe or fixed really shouldn't be the norm. So let's take a look at some of the clinical signs in the hands. So we see severe sclerodactyly on the left and severe dorsal ulcers on the right. And just as a sidebar, I mean, many years ago in the late 70s and early 80s, in RA, we saw horrific hand deformities, forearm deformities, carpus falling off the end of the radius and ulna, MPs at 70 degrees of ulnar deviation. And that's really been averted quite a bit by the use of early care and medical management. And my hope is that as biologics and other treatments emerge, that seeing hands like this as a result of scleroderma will be rare. So the key concept in scleroderma is that it's considered a deficient angiogenic condition. So you see the ulcers on the left and then the actual autoamputation of digits on the right. We're going to be talking about this a little bit more. The tissue changes at fingertips can vary in presentation. So you see on the left, that cuticle, it almost looks like an eschar. It's sort of crusty and dry. And then you see the ulcers and the blue tissue on the left. This is a left-handed individual, and those are the load-bearing surfaces of her fingers. So angiogenesis, when there's reduced angiogenesis and there's capillary damage, There's hypoxia at the fingertips, and that hypoxia has a role in acroosteolysis. Acroosteolysis is destruction of the fingertips, including bone. It's usually caused by vasospasm. It's characterized by Raynaud's. So this is highly associated with scleroderma, with diffuse scleroderma and limited. And you'll actually see shortening of the pulp at the end of the finger, and the bone upon x-ray is actually partially resorbed. There's calcinosis, both superficial and deep. It's really poorly understood, but it's hypothesized that calcium precipitates in tissue damaged by local trauma and hypoxia. So there's all of this sort of fits together. It's not well understood, but it's seen clinically in association. So that's what we're working from, that observational occurrence. And on the left, you see all the calcium deposits along the ulnar border of the small finger at the MP, along the ulna. In the right hand, which I'm going to assume is the dominant hand in this individual, you see all the calcifications along the ulnar border of the thumb and the radial border of the index. Again, most often on the load-bearing surfaces of the hand. If you look at the fingertips right next to that, you'll see yellowish white bumps. Those are actually small pieces of calcium that are attempting to extrude themselves from the soft tissue. And I am told, and I fully believe, that they're extremely painful, and they also put the person at risk of infection. In the bottom on the right, you see the x-ray first with all that calcification all along that bone and back of the olecranon, all load-bearing areas. And then you see what it looks like on the skin, again, extremely painful for the patient. So let's look at what the hands might look like. On the left, you see a woman between the ages of 65 and 70 with scleroderma. This person happens to have limited. And on the right, a typical 66-year-old pair of hands. The differences are clear: the tightness of skin, the strange dimpling over the PIP joints, and the shiny appearance, and even the hyperpigmentation, the yellowish brown look. You can see that crescent-shaped skin on the dorsum of the PIP. Now, it's my experience that that's very, very classic, that there's a lot of tight tethering of tissue on the back of the middle phalanx. When the person extends their fingers, instead of having that sort of oval shape of redundant tissue on the back of the PIP, the tight tissue on the back of the middle phalanx pushes back up against the skin on the top of the PIP and gives you a crescent look. I tell my patients they have a frowny face on the back of their PIP joint. And if you look carefully, you also see some vitiligo, which is an autoimmune response of the body as well. And then if you look carefully at the thumb, it's quite shortened. So there's obviously some acroosteolysis there. The end of the thumb is shortened. The thumbnail is short and blunted. And that's kind of a classic looking scleroderma hand as well. So you can see they're all a little bit different, but have some consistent features. Now, you'll also notice that there may be damage to load-bearing surfaces of the hand. So if you carefully look at that, the radial border of that index, it looks a little bit hyperpigmented right along that edge of the middle and distal phalanx. And if you were to palpate that and touch it, it feels very coarse, very hard, and very rough, almost like a callus, but sort of a different quality. On the right side, you see the companion ulcer on the ulnar border of the thumb. So then again, you see that pattern. It's something to look for, something to watch for, and something to educate your fingertips to recognize. Here's a classic, or just one of the patterns of motion that you may see. The upper left-hand corner, you see maximum hand opening. You see the blanching of the tissue all around the web space, all the way, it actually tracks all the way up to the PIP. You see some vitiligo on the back of the hand, that tightness of the PIP joint. Then when the individual goes to close their hand, you see the limitation laterally and also volarly. It's been my experience that the index finger tends to be the most beat up digit in the scleroderma hand, the most complaints of pain, the most stiffness, and sometimes when they present as a puffy hand version of diffuse scleroderma, they'll complain that it's the most swollen. And my speculation is that it's because it's the most used, the most beat up finger on the hand, and it is typically more symptomatic in the dominant hand. So let's take a look at this. Let me go back here. This is normal tissue movement on the back of someone's elbow. This gentleman is in his late 60s. And here is an individual with diffuse scleroderma, and if you look, it's stuck. It just will not move over that weight-bearing portion. Again. So these are things that you can observe. So now that you've seen a few symptoms and what might be occurring in the scleroderma hand or the upper extremity, what should give you pause during a patient assessment? Let's say you get a generic referral from a primary care doctor and the complaint is hand pain or maybe Raynaud's or carpal tunnel syndrome. Well, we want to learn how to see these early signs when the person hasn't been seen by a specialist yet. So if there's a history of Raynaud's phenomenon, a history of carpal tunnel release with poor outcome, maybe swollen hands. Now what's interesting, I've recently learned that you might speculate that a poor carpal tunnel release outcome would be affiliated with fibrotic or tight tissue across the carpal tunnel in this population. Well, actually, it's hypothesized that it's a primary vascular damage to that median nerve because there's no compression noted with ultrasound. There's no narrowing of the median nerve like you would expect. So that's an interesting thing. So it's vascular, not compression. The other thing you might see is indurated tissue, just a little bit harder than you think, and shiny skin. Maybe the person actually, in a nice way, looks younger than their stated age, the hands, forearms, and possibly the face. There may be skin hyperpigmentation or discoloration. Now, tendon crepitus, also known by rheumatologists as tendon friction rubs, are really very, very common, particularly in diffuse. It goes beyond the finger flexors that we're all used to seeing and feeling, that crunchy thing. It actually happens in wrist flexors and extensors, finger extensors and flexors, ankles. There's complaints of it occurring in patellar tendons as well. There's also complaints of joint pain, especially distally and bilaterally, and there can be complaints of generalized fatigue. If you have concerns, this is a key issue. You don't want to use the word scleroderma ever in front of the person or a family member. You don't write it in a chart, and don't suggest it as a possible diagnosis to the referring MD. As you well know, as therapists, we're just supposed to be superb observers of symptoms and really good at recording it and giving that information with clarity to the physician. To use the term scleroderma is really very problematic. I've had multiple patients who've been told horror stories about scleroderma when they were going through the potential of being diagnosed with it. And, even statements like, oh, be glad you don't have scleroderma, that's a death sentence, only to go on to a specialist and be diagnosed with scleroderma. So you can imagine the emotional trauma that does to the individual. So we really want to be very judicious, but very clear. Calling the MD and presenting your objective findings is your greatest strength. Raising the possibility of the person seeing a rheumatologist. Those are all within our licensure, but it is a very, very fragile process for a person to be diagnosed with this disease. So where do we start as a hand therapist? Since we know now that scleroderma is a disease that can significantly damage the vascular supply to the upper extremity with severe and permanent tissue damage, we want to intervene early with a systematic approach based on the pathology of the disease. We want to educate ourselves, be educated by our patients, educate others, and involve family members. So it's the little things that count, hundreds of them. The place I start is with ADL adaptations because it's so critical with this population. Some of the things I'm going to talk about are very common, and we all know them. I'm not going to labor them and spend a lot of time on them, but I want you to see them and think of them through a vascular prism, not just a comfort or joint protection prism. So we've discussed the vasculopathy with scleroderma. I mentioned Dr. Chang here because of his influence on my journey in the past few years. I listened to a webinar in late 2017 of his that was really directed to patients with scleroderma. The vulnerability of the ulnar artery was discussed in vivid detail, and I suddenly had an epiphany about all the most difficult problem areas in the upper extremity with this population. It just all sort of like came together, and what I'd been seeing for years into a much more cohesive way of thinking and a more cohesive approach as a hand therapist. The pattern of hypoxia and fibrosis made much more sense. So when we talk about ADL adaptations, we want to talk about environmental factors to consider. It's the effect of excessive cold and excessive heat on the health of the tissue, especially fingertips and toes, the effect of hard direct pressure and vibration on vascular tissue health at the fingertips and over bony prominences, the effect of friction, microtrauma, and shear force, as well as chemical exposure on inelastic, fragile, and healing tissues. So cold exposure and Raynaud's, together with fibrotic tissue, make it especially difficult to manage in the scleroderma upper extremity. As we all know with this Raynaud's, it's easier to stay warm than to get warm. You want to keep your core and head warm, your arms and wrists warm. And when we look at this through a vascular prism, we have to remember that excessive cold and excessive heat can be damaging. So don't be misled that warm is great, because you have to think of it, I explain it to my patients like it's a radiator in a car. There's a malfunction of the coils in your radiator and they're rusty, and so not only can it get cold too easily, but it can get overheated and not cool itself in a timely manner, which could result in further tissue damage. Also remember, in that early slide we talked about the ischemia reperfusion possibly being a mechanism of vascular injury. And so we really want to keep the temperature or at an even keel in the upper extremity and avoid vasospasm as much as possible. So I like to teach my patients to be aware of capillary refill time. It's an age, gender, and temperature dependent phenomenon. The average is anywhere from 2.9 to 4.5 seconds. And it's longer with scleroderma. I can't give you factual seconds, but I just know that I have each individual patient of mine watch for their capillary refill and pay attention to how long it takes for their fingers to pink up. And what we talked about with the ulnar artery and vasospasm and early vasospasm, it's interesting to note the blanching of the ring and small finger in this photo. So we know about all these great products. I just want to reiterate that heated gloves, one has to be cautious. You don't want the fingertips to get too hot. I don't want my patients using those chemical heating packs in the bottom of their mittens with their fragile fingertips resting directly on them. On the far left, you see what's called a wristy. It's a great product. My only comment would be that it's, in my world, it's being worn upside down. I want the chemical pack to be laying over the volar aspect of the hand in the area of the radial and ulnar artery to dilate them, not on the back of the hand. It's far more effective on the volar side of the hand. So there's sun loops on the left. Sun loops are also a great product. Again, I would turn them upside down. I would have those on the palmar arches of the hand. They can also be slid up on the forearm so that the chem pack sits on the volar aspect of the wrist, dilating those blood vessels. On the right, you see one of my creative patient's ideas. He just cut off an old pair of crew socks and put his hot hands in that and put it around his wrists, and then discovered that thermoband at the bottom, which apparently has been used by people in the trades for a long time to keep their hands warm. And they put it on at the wrist, and it's really this is really a great approach for that mid weather sort of thing. Once it gets below 65 degrees in the early mornings here in the Northeast, it's really rough. We want to avoid vasospasm, and so it requires a lot of strategies and a lot of creative thinking. This is a homespun version. This is made with simply polar fleece, inexpensive, very inexpensive. And again, you can cut it out, very simple pattern, and the chem pack can be all the way over on the ulnar artery or can be centralized, whatever the person likes. And people love this for working inside the house on winter days up here in the Northeast because they want their hands free for use, or maybe they're typing at their keyboard and they want to stay warm and perfused at the same time. So in addition to the whole issue of cold, we want to talk about pressure and sustained pressure. Operative word being sustained or prolonged pressure causes problems in the upper extremity for scleroderma. Pressure causes vasoconstriction, which can cause damage to blood vessels and surrounding tissues. This can result in excess collagen deposition as well as calcinosis. Individuals with scleroderma have decreased angiogenesis in response to damage. Many have absent pulses in their ulnar arteries. Weight-bearing surfaces of the body are much more prone to this tissue damage from pressure. Fingertips, dorsum of finger joints, hypothenar eminences, ulnar border of forearms, elbows at the olecranon, those are all high-risk areas. And it actually may be possible to feel a qualitative difference in the dominant versus non-dominant extremity with palpation, and I've noticed that difference all the way up the forearm to the elbow. So this is an example of one of my folks who got a Fitbit for Christmas, and I hadn't seen her for about a month. She came in, took off her Fitbit to start treatment, and lo and behold, we noticed this dent. We were both sort of startled and looked at it at the same time. And she turned her hand over, and there's that hyperpigmentation that is often affiliated with fibrosis. It's right along the ulnar artery, the one place we don't want it. And it was insidious. She had no idea. So this is a great example of that. The good news is that further up in the forearm, there seems to be a little better tolerance for this, even though she had that occurrence. As soon as she stopped and started wearing it on her waistband or her shirt, the indentation resolved, and actually some of the hyperpigmentation decreased. So it was a good catch, and surprising to both of us at how quickly it occurred. You can see her crescent-shaped PIP skin there on the bottom on the left as well. So the ulnar side of the wrist and hand. The ulnar artery lies deep to the pisiform. It's shown so what I wanted to discuss here is that in 2018, I listened to another great webinar by Dr. Cheng from Stanford, and this time he was joined by Susan Clark, OTR CHT. It was an update on hand surgery and therapy for the scleroderma hand. And during this discussion, Dr. Cheng discussed intervention with the ulnar artery, some things he had tried surgically, and he explained his findings with ultrasound imaging. He noted that in flexion, the ulnar artery flow was reduced but maintained. However, in extension, it was fully occluded. This became another pertinent fact for ADL adaptations with this population. It's not just pressure, but alignment for sustained periods of time. So here, these are common things we're all familiar with, but looking at it through a maintaining blood flow prism, it takes on much more importance and much more meaning. I love those little elbow pillows on the right. They slide over the top of the armrests of a desk chair, just like a shower cap. They're really great, and they're under $15. But again, the buy-in, the buy-in with the patient is educating them about the importance of really carefully keeping pressure, sustained pressure off of that ulnar side of the forearm, as well as maintaining good wrist alignment. So this is a creative idea one of my patients came up with at home. She took this picture for me, and she decided that she needed to keep her hand warm. Even a wooden desktop in the Northeast when she's working from home would cause vasospasm. So she went out and bought one of those memory foam bath mats, which you see here she placed underneath her laptop along with her gel forearm support. It's a great mouse pad. It kept her arms warm and prevented vasospasm. So my patients always have the best ideas, honestly. So whatever works best for a person's budget. You know, it doesn't have to break the bank. Those horseshoe pillows and neck pillows, they can work for forearm support. I've seen them at Five Below. They can be purchased relatively inexpensively. I've also had people use yoga mats and cut them up like placemats. Let's say, for example, they like to sit at the kitchen table in their breakfast nook or whatever, looking at their iPad in the morning, or even when they're sitting eating breakfast, taking 1 or 2 layers of a yoga mat, cutting it up and making it into a just sort of a mat underneath their upper extremities at the table. It just is one other small way of reducing sustained pressure and trauma to that area. So, of course, we all know about gloves, but the thing I want to talk about here is that the pad has to be, you know, relatively generous. I don't think just a basic weightlifting glove would do. I'd prefer to see something that has a nice palmar padding, particularly over the hypothenar eminence. I love the WAGs. They're a little bit pricey, but they're great. And this came to light when I had a patient come up from PT and complained to me how much his hand hurt when he was doing these TheraBand lower extremity stretches in PT. And I was, you know, once again embarrassed to not have thought about the impact of him using TheraBand. You know, I hadn't used it with him in OT, but it was just like an unforeseen, but it was quickly fixed with the use of a glove, and it worked very well for him. He could continue the exercise. So we know about excessive and sustained gripping. We know about that from arthritis. But again, looking at it through the prism of vascular support, mini breaks and adapting when necessary, using good tools, padding things. Once again, we all know about that, but this is again to prevent the horrible ramifications of acroosteolysis or autoamputation or increased hardness, proliferation of hardness at the fingertips. So you always want to protect the fingertips from pressure. I really like the little tippies. I'm going to illustrate that in a moment. And again, that simple idea of open versus lateral pinch holding of a plate. Remember the previous picture with the breakdown or the thickened skin on the radial side of the index and the ulnar side of the thumb. This is a good illustration of why it's all about vascular support. So we know about using the right tools, enlarged handles, work harder, no, work smarter, not harder. And there's many things available, although I would say in all these pictures for gardening, especially in use of tools, I recommend gloves, and we'll address that in a moment. So now let's talk about friction, microtrauma, and chemical caustics, the terrible triad of fingertip trauma. Yes, I came up with that on my own. So let's look at this. In systemic sclerosis, key factors that contribute to vascular wall remodeling are shear stress, chronic hypoxia, and inflammation. So we keep reiterating that, integrating that into what we're talking about. And now a quick look at normal friction absorption by the fingertips. So here's sort of a normal fingertip absorbing friction as it should. And that does not occur in scleroderma. The fingertip is hard, it is damaged by shear force, it's damaged by friction. So one of the things that I'm a big fan of, and I use a lot in many different applications with this population, is what I call the layered approach. So on the left, that's my husband modeling those gloves. So that cotton glove on the left really doesn't fit him properly. It shouldn't be that tight. But I am a huge proponent of using Cara 100% cotton gloves as a liner. It gives padding, absorbs perspiration underneath any type of a friction glove. There's a nitrile glove. So if you wear a medium cotton glove, you'd go up a size and use a large nitrile. And then the nitrile glove absorbs the friction, and the cotton glove absorbs perspiration and some of the pressure and microtrauma potential with a little bit of padding. Same approach for the elbow. Never use that heel bow solo. The inside of that is awful. It's rough. We all know that. It can be reduced a little bit with the use of a cotton liner, but again, all of that has to be carefully monitored. And the neoprene in the bottom left, I would never use solo. I would also use it with some kind of a liner. So The grip assist gloves work great. They have multiple uses. Again, a cotton liner. They can be used, would be used as a companion. These can be used outdoors. I tell folks to have one in the kitchen. They can use it for meal prep. That way when they go into the refrigerator and they're going about using their hands for getting items out of the refrigerator, it's great. They can keep them in the laundry room. It's great for opening things up in the bathroom. So a lot of these things are fairly inexpensive. That, you know, the most important thing is that the things are readily available. Like we tell our arthritis patients, don't get into something that you can't get yourself out of quickly. And we all know it's human nature to see something and want to deal with it immediately. And if the supplies are there and at hand, they can be quickly grabbed and donned. And it's just one less micro trauma or one less event of the day on that fragile tissue. Here's how I like to use the Tippy fingertip protectors. Always use layers when dealing with healing ulcers. I'm going to talk a little bit more about healing ulcers and the problems associated with that later on. But this can be used as a dressing. And then the silicone is great. It absorbs shear. It gives friction while someone has a cotton liner on it. Again, you have to be careful of fit. You have to be careful of pressure. You never want a tourniquet effect with any of these. These do come in various sizes. They're about $1 a piece. So I really want to talk here. I'm going to interface this now with the ulcer issue. So I just had a patient the other day with a terrible problem with ulcers, and she was talking about how painful washing her hair was. So if you think about what we already talked about, you've got this hard inelastic epithelial layer of tissue. And we know that wounds close in a purse string fashion where the epithelium advances to close the granulation tissue. Well, that's not going to happen very effectively in scleroderma for a number of reasons. Think back to the nail fold capillaroscopy, what that architectural bed looks like. Think back about what we know about granulation tissue and the borders needing to be soft and advanced to cover the granulation tissue. So when you put in the mix, water, warm water especially, and a surfactant like soap, now you're hyperhydrating and softening that granulation tissue and applying friction at the same time. It's disastrous. So you see here simple options. I had someone who insisted on, she came to see me because of terrible ulcers again, and she had ulcers that advanced up under her fingernails into her nail beds. And I just can't imagine how painful that is. I can't even handle a finger split. And she insisted on grooming her Goldens herself. And so we came up with a compromise and a way for her to do that without destroying her fingertips. I'd probably also suggest that she wear the layered approach of gloves just to protect herself, but all of that can be figured out by the patient and collaborated with a therapist. Again, the dishwashing glove in the middle, I would have that lined with a cotton glove as well for all the reasons we just talked about. So you want to arrange cupboards to prevent fingertip collisions with dense objects. By the way, my patient with having all the pain with washing her hair said the most painful thing is when she was trying to wash the top of her head and her fingertips were hitting each other. So don't underestimate the trauma that causes to fragile and healing tissues. So you want the kitchen cupboards to be arranged with heavier, denser items at eye level, school lockers too, store items that are used most often, nearest and at the best height for reaching. Obviously that spring pan that you might use for a cheesecake belongs somewhere way out of your mainstream. You don't want very rarely used objects getting in the way of your routinely used objects. And good lighting in cupboards and bathroom closets are great now with the advent of LED lights that are battery operated. I've even seen them at the dollar store. You don't have to rewire your house in order to get decent lighting and better visualize what's going on. And by the way, who wouldn't love that beautiful open pantry on the right? So not happening in my household. So we want to avoid tight storage as well. It's also common sense. I know all of us have someone in our life that insists on carrying a meatball around in their back pocket, and those are not a good thing for the fingertip in scleroderma. Of course, there's, I don't even want to say what I think about that cosmetic bag. And then a tight leather clasped handbag is a virtual disaster for fragile fingertips. There's pull-out options for cards, as seen on the left. This middle is something my patient came up with. He came up with this before I actually met him. He was having a lot of trouble with digital ulcers, and he really figured out very wisely that digging around in the bottom of his denim jeans pockets to get items was really a big contributor. So he drops in the items to the top part of his pocket and leaves a lanyard on the outside so he can just pull it out with a full palm. So that's one solution, and there's a lot of variations you could come up with on that one. And then, of course, a loose bag with only the most important things stored in a logical manner. So one other thing to think about, this is a big thing, and it was another epiphany for me, using nitrile gloves with cotton gloves when you're in the kitchen prepping. So we know that tomatoes and citrus are acidic. It's very, it can be very damaging to ulcers that already exist, but also people who have chronic ulcers and repeat ulcers in the same zone. The tissue in that part of their fingertip is very vulnerable. It's very fragile. So those caustic juices, even, it's just no reason to expose yourself to it. Citric acid is common sense, but organic disulfide was kind of a shocker for me. I came to, this was another epiphany I had. To illustrate this, this is my best friend's mother after her well-meaning brother applied a poultice of crushed garlic overnight to his mom's arm because he thought she might get an infection from a bug bite. And she wound up in urgent care for this. So that is a very caustic substance and really should be avoided. So we don't want people to avoid cooking. We don't want people to avoid meal prep, but we want them to be smart about it. And of course, avoiding harsh chemical exposure is extremely important. Again, it's hard to believe, but I had somebody with chronic ulcers who was rather shocked and disturbed that I told her she shouldn't be cleaning with bleach water, which was one of her favorite ways to clean. So we all know these are cytolytic agents and very damaging to tissue. There are safer alternatives we all know about, but one little word about essential oils. They should always be diluted properly in carrier oils. Believe it or not, I've seen people burn themselves with undiluted peppermint oil applied to an achy joint. So just because it comes from a plant doesn't mean it's harmless. So now we're going to talk very briefly about avoiding contractures and improving tissue quality and how can we help as hand therapists. And this is a very basic overview of this whole concept. I just want to talk about the main concepts, the big picture. There's much more to share and much more detail and much more micromanagement in the mind of Celeste that I don't have the time to share today. But you have to start with a classic sort of upper quarter screen, but you want to include skin integrity and skin quality. You want to look for what I call skin banding, which is actually a stolen term from back when I was on a burn unit when we called scar banding. And that requires taking a look at a composite motion, almost like a median nerve glide or a brachial plexus glide, where you bring the whole arm out into abduction and elbow extension and wrist extension and actually put the chin up a bit, and you look to see where there are primary areas of banding. This is particularly evident in people with diffuse scleroderma because, of course, limited, it's not going to be involved up in that area, but you have to look at all of that area in a little bit of a different way. You want to know the disease fundamentals and be teachable by your patients. I've learned so much from being open to their suggestions, observations, and their consumer input. You also want to apply the pathophysiology of the illness to the approach used for intervention and customize it for the unique needs of your patient. So let's talk about the use of emollients overnight. This is just a starter kit. I have all my patients do this. They can have little mini cracks in their fingers. They can have little mini ulcers. They can have just super dry skin, or they can actually have overt ulcers. And there's lots of different products. Again, if you recall what I was talking about, the hyperhydrated granulation tissue, I'm not a fan of water-based things. I really prefer greasy things. And The cotton glove is great obviously if you wash your hand and apply an emollient. You don't need to wash the gloves every day. You probably want to wash them maybe once a week. There's not a problem with some buildup of product inside the glove. It's a little different if you have actual wounds. You have to manage that a little differently. I've had people who love Meta-Honey, but by and large, the preventative that I like is use of any of these products in conjunction with cotton gloves overnight. So we want to pay attention to the height of hands and forearms, and it should support blood flow. It's a little counterintuitive to our classic edema reducing positions. One little sidebar. When you have somebody with very puffy or swollen edematous hands with scleroderma, at which some people present with, it's pretty problematic. So you have to choose sort of a mid-range. There is an article discussing manual edema mobilization for that swollen hand, which is more like a physiologic swelling. I had one patient try it. He had limited success with it. If you contact me, I can let you know. I can direct you to the article. But with most folks who don't have real puffy hands or have sclerodactyly, this is the way you want to position them. Now this is interesting. So the use of hot packs and soft tissue massage. Now here we have a little bit of a paradox. The presence of vascular pathology at one site doesn't necessarily indicate similar pathology at other sites. Large size vessel occlusion in systemic sclerosis is unusual. However, it can occur, as we know, in the ulnar arteries. So people that I treat really like soft tissue massage. You have to be careful. Most of them have myositis. And so it requires a lot of feedback and careful application. You never go over bony prominences, and you never go after the fingertips in particular, or any area that is excessively indurated or hard. But my folks tell me that it provides relief and they can move better, and they like it as a prep for treatment. I do pisiform and flexor carpi ulnaris mobilization with this population. That ulnar artery sits right underneath that structure. If I drop the wrist down in a little bit of flexion, I can do a lateral mob, as you see on the right. You can also do a mob with the person standing. Sometimes, if you really want to keep that hand perfused, you can do things upright and work on that extremity with the person standing. So, on the left, you see forearm massage. I just want to make a little comment here. One of the things that I like, well, I'll suggest to patients who have real difficulty with finding blood vessels for phlebotomy is to do sort of like a back and forth roll of the soft tissue in between your hands, almost like you're rolling a Play-Doh snake out, you know, if you will, just rolling the epidermis back and forth, and then sort of slowly, gently going down the arm to try to increase pump, vascular pump in the arm, and hopefully make the blood vessels easier to find. On the right, you'll see me doing an extrinsic forearm stretch. Patients really like this after massage, but the hold time is shorter. So yes, I'm sort of breaking the rule with the flexion and extension patterns, but I keep the arm in a lower position. We watch for perfusion. It's not done constantly. It's not sustained. And as we said, it's when you're looking through that vascular prism and paying attention to the individual response of your patient, I believe it can be safely done. I also use a Bunnell block prior to tendon glides and for home exercise program. I'm showing the hand in the upright position on the left so you can see the clearance of the PIP. I really like NCM Preferred. It's smooth, it's the 1/8 inch. It's very comfortable against the skin. There's a strap on the back for easy access. Sometimes people with significant contractures or tightness need to have a loved one help them get that on and off by splaying it open. There you see the side view, but I have them do it at waist level or in their lap. Individual tendon glides and composite tendon glides are super important, very, very important. And the overall approach that we emphasize here is that it has to be customized. It depends upon, with the hand, when we get out into the hand, and like I said, there's so much more to talk about, but it depends upon the predominant pattern of deformity that the person presents with. Some may tend towards an intrinsic minus, some may trend towards an intrinsic plus. Use of an orthotic early and with great caution can be tried. It has to be self-monitored, monitored by you, and there is a place for it. It's just with caution and absolutely a problem in severe sclerodactyly. It's really not successful. On the left, you see my patient stretching her MPs into her own thigh with in a downward position, so she has great perfusion and she's holding it to a comfortable point for a comfortable period of time. Again, it's not long stretches. It's not 30-second or 45-second stretches, but it might be brief, repeated, shorter stretches. Big fan of isometric grip strengthening. Not only does it strengthen the hand, if the posture is good around these tubes, it's great for concentric strengthening and concentric stretching. And it can be done sitting in the lap. This is just for purposes of demonstration. I had my student do this up on a tabletop. Frequent soft tissue stretches are the safest. You want to monitor for fingertip pressure and or tourniquet effect with anything you use. And sometimes because sensation isn't great, you have to be hypervigilant as a therapist. You have to watch and make sure for the person, have them lean over and take a look, sort of a 360 look at what the hand looks like in the position and the materials they're using. The yoga sock on the right is I have 2 or 3 patients I've tried it with so far, and for the right person with the right fit, it is very comfortable and can be worn for short periods of time. In the evening, maybe when you're relaxing, to just do that nice the web space stretch of the hand. Again, there's ways to stretch the wrists. As previously mentioned, you're going to use multiple angles from pronation to supination. The ball shape helps avoid direct fingertip pressure with stretching, and prolonged position is avoided. So this is a variable way. We also can use this soft weight for some light strengthening because it's not going to beat up on the fingertips because it's soft. You can also just use one of those mini basketballs from the dollar store that's foam. It doesn't have to be a weighted ball, obviously. This is a way to stretch the elbow out. Again, it's using the 3-point pressure approach. I assure you on the bottom right that the fingertips are fully cleared of the wall, and the patient leans into the pillow, uses the soft torso against the back of the elbow, and the other 2 points of pressure come from the pillow. Upper quarter stretches should optimize distal extremity perfusion. In the upper left, we see somebody using a physio ball. If the person can't get up and down from the floor to use a physio ball, or they don't even have a physio ball, you can also accomplish the very same stretch using multiple pillows seated at the couch. Again, if it's diffuse scleroderma and there's tightness along the anterior chest and the axillary and the chin, I have my patients pull their lips into their mouth, tilt their head back, and spread their hands out. And on the right, you see similar stretch. This can also be accomplished on a bed top. You know, just roll up an old blanket or quilt and accomplish the same thing. And one other little word of caution: if somebody has pulmonary issues, they're going to have to sit upright, so the couch stretch is probably better because lying down flat compromises their respiration. So that's a quick overview. In summary, we have a unique and potentially exceptional role in the early intervention and long-term management of individuals with scleroderma and its various and challenging presentations. I firmly believe we have an opportunity as upper extremity experts to lead the way in treatment, education, and in cultivating proactive relationships with rheumatologists in particular. This population remains underserviced by the medical community. If you have any questions, feel free to contact me. My granddaughter certainly had questions about her baby sister. I'm more than happy to answer your questions. Thank you so very much for your time today.